everyone, and sorry for this brief technical delay. Thank you, Dr. Ahmed, for organizing this important webinar. And I have a very brief presentation on the use of ventilation and lung ultrasound in COVID-19 patients. So moving on to my presentation, I would like to, in the beginning, to highlight probably one key message. If I want to summarize the whole idea of my presentation from what we saw in these patients so far, is that we need to be patient with them and we need to give them time on the ventilator if we decide that they will need to be on mechanical ventilation. So as we can see in this slide, which is showing us the time course of the development of ventilator-induced lung injury in patients who develop ARDS induced by mechanical ventilation, which is about 40 hours. And it's important to put in consideration the harmful effects of mechanical ventilation and the harmful effect of the potential negative inspiratory pressure of the patients who are breathing spontaneously. And I'm starting with this because we know from our evolving knowledge and experience about COVID-19 that these patients have various potential mechanisms underlying the problem they have. They have probably an element of lung vasoplegia due to loss of the hypoxic pulmonary vasoconstriction, which consequently probably lead to elevation in the nitric oxide level and also probably reduction in the production of angiotensin II, which all lead to alveolar flooding and a massive VQ mismatch. It's a different type of VQ mismatch that we did not often see previously in the usual patients presenting with respiratory failure, because this type of VQ mismatch is typically or commonly characterized by normal ventilation. That's why they come usually with a sort of preserved lung compliance, but they have an increased lung perfusion due to this element of vasoplegia and alveolar flooding. And this massive change in the ventilation perfusion ratio is probably the cause of their severe hypoxemia. And this is also an illustration of the effect of the initial lung injury on the development of alveolar edema due to capillary leak, with worsening in the lung mechanics and gas exchange, which lead to a vicious cycle of further capillary leak and a progressive worsening of the lung mechanics and the hypoxia. So this is one theory, and another theory could be the development of microthrombi. As Alexander said, we know that this disease causes high thrombogenic potentials, and we see patients developing PEs, we see patients developing very high levels of the D-dimer and fibrinogen. So the role of ventilation will be decided upon understanding the progression of the disease. So once we decide that the patient will need to have a sort of ventilation, we need to see whether they will be eligible for non-invasive ventilation or they will require intubation and ventilation. So we often, I work in cardiothoracic intensive care, and we often have patients already intubated in our unit. We don't have emergency department, so we don't intubate patients coming to the hospital. We usually have them intubated and referred to us from another hospitals. But we do know from our colleagues working in accident and emergencies across the country and also in other countries in Europe and in the world affected by the COVID-19, that these patients may have severe levels of hypoxia without symptoms, or in other words, without significant dyspnea. And this probably could be explained by the compensation they do by increasing the levels of tidal volume rather than increasing the respiratory rate to match the respiratory needs. So you can see patients with saturation of 60–70%, they are not dyspneic. And that's why there were trials of starting non-invasive ventilation on these patients, especially if they don't have significant affection of the lungs in the beginning in their imaging. So we have some advantages from starting non-invasive ventilation. It may help the oxygenation. It may reduce the swings in the negative inspiratory pressure triggered by breathing. Especially, we do know that these swings may be very harmful for the progression of the disease, because if the patient is working hard to breathe spontaneously with an acute fluctuations in the intrathoracic pressure, this can cause cycles of increase and drop in the venous return, which will lead to cyclical lung edema and a cyclical hypoperfusion of the lungs due to these acute swings in the venous return, which may cause a progressive worsening of the oxygenation. But we do see in many centers that the intensivist and emergency physician opt to intubate these patients early on and not trying non-invasive ventilation because of the understandably risk of aerosolization and a very high infectivity level of these patients coming in the early beginning with respiratory failure. But on the other hand as well, when we try non-invasive ventilation, it may be harmful for the right ventricular function, and it may cause or trigger the development of acute kidney injury on the long term. And these are the two important phenotypes of the COVID-19 as explained or suggested by Luciano Gattinoni. We have the common type L phenotype, the one at the top of the screen, which is commonly presenting by preserved lung compliance, not typical ARDS presentation. They have severe hypoxemia, and they have no recruitability or very low recruitability of the lung. And they also have a low of the lung, reduction of the lung elastance. And actually these two images, these two CT images are from the same patient. The first patient was breathing spontaneously for 7 days. And we see in the CT scan the typical peripheral ground glass infiltrations, which are typical for COVID-19. And after the patient left for several days, breathing spontaneously, and then tried for longer intervals on CPAP, non-invasive ventilation, with probably trials of giving him fluids because his blood pressure was dropping, we caused iatrogenic transformation of the patient from the classic type L to the other type, which is the type H. The type H phenotype of the COVID-19 is the type almost similar to ARDS, where you see these very bilateral dense consolidation and extension of the ground glass opacification. And you can notice here that the level of hypoxemia is almost similar in both phenotypes, but the lung mechanics are very different. So before deciding for which types of ventilation we are providing and which modes of ventilation and which settings of the ventilator we are going to put, we need to know which type or which phenotype of COVID-19 we are treating. So on the left, type L, on the right is type H. And setting the ventilator will be decided upon knowing the compliance of the patient. So as I just mentioned, that type L is usually characterized by reduction of the elastance, reduction of the VQ ratio, reduction of the lung weight, and lower recruitability. This tells us that you should cautiously use PEEP in these patients with type L. Otherwise, you will cause overdistension, and you might not help the lung, but you might cause injury and more harm to the lungs. But on the right side, the type H, which is the classic or near to the classic ARDS type, they have high elastance, increased shunt level, high lung weight, and this is the type that may benefit from recruitment with PEEP. So how do I set the ventilator? Again, so let's say we decided that our patient is the type L, which is commonly the type we see in our units, but we also see the other types as well. So type L, you can use either volume control or pressure control mode of ventilation. There is no definite answer to the mode of ventilation. So it depends on what you are familiar to use. So the mode of ventilation, as some people call it, is like the type of car. So whatever you're familiar of driving, whatever you are good at, do it, whether it's volume control or pressure control. The tidal volume, we noticed that, and some authors noticed that these patients, because they have normal compliance, you should not give them the standard lung protective ventilation that we often give for patients with ARDS. Because if you give them low tidal volume, you put them at risk for resorption atelectasis, and this is not a good thing in such patients. So you should give them a tidal volume in the range of 6 to 8 milliliter per kg. You should start with high FiO2, high oxygen, and then try to titrate depending on your targets of oxygenation. We usually target a PO2 more than 8 and saturation more than 92%. Your respiratory rate, you don't also give them high respiratory rate, unlike ARDS. So you try to aim for a respiratory rate less than 20 breaths per minute. Your PEEP, as I just mentioned, you need to be cautious with the PEEP. They can usually be managed with PEEP of 8 to 10, not more than that. Proning was found useful in these patients, which was a bit counterintuitive because we do know that proning is classically useful for patients with dense basal consolidation. And these patients do not have usually basal consolidation. When we scan the lungs with lung ultrasound or CT, we often see the pattern of curtain-like B-lines in a patchy distribution with no lobar consolidation. Or on the other hand, with CT, you often see the ground glass appearance with no consolidation. But we found with experience that these patients do well with proning, and this probably could be explained by the redistribution of lung perfusion with proning, and also some suggestion that these patients have microatelectasis, which could be relieved or improved by proning them. So we do series of proning for these patients, and some center even do extended series of proning, up to 5 or 7 proning sessions. And the proning usually is from 16 to 18 hours in proning position, and then the rest of the 24 hours will be in supine position, and then you can repeat that every day if clinically indicated. And of course, when these patients are proned and managed on the ventilator, you have to sedate them and paralyze them. They have to be comfortable. And I think the most important message I want to give from this presentation, one thing, be patient, because one of the very dangerous and one of the very bad consequences of ventilation management in these patients is our temptation to wake them up early when we see the FiO2 improving down to 35 or 40%. And then we attempt to extubate them. And we suddenly see these patients deteriorate if they are extubated early on, which is one of the challenging problems that can transform the patient from type L to type H when they are re-intubated, and then the mortality rates gets very high. So patience is very important, and we noted that these patients usually take on the ventilator at least 7 days, and ideally 10 to 14 days, even if they are requiring lower FiO2. But it does not necessarily mean that these patients are ready yet for extubation. And I found that lung ultrasound can be useful and guiding in this setting. I have seen several patients with improving FiO2, 35 to 40%. And when I scan the lungs as part of my daily assessment of these patients, I still see a significant degree of alveolar edema and curtain-like B-lines across the lungs, which is an indicator of the level of aeration. So I often feel more comfortable to extubate my patients when I see predominant A-lines pattern, the predominant pattern of normal aeration across the lungs. We don't expect the B-lines to disappear, but I'm talking about the predominant pattern across the lungs in different zones. So my key message here, be patient with these patients. Don't wake them up early and don't extubate them unless you are comfortable. Usually 10 to 14 days is the average. There's no solid cutoff or solid number. It is all your clinical judgment, but this is what we saw and our colleagues saw in other centers as well. The other type, the type H, is similar to the classic ARDS type. And again, the mode of ventilation, you can use volume or pressure control, depends on what you are familiar with. And here, because they have dense consolidation in the lungs, they have low compliance, you would use the lung protective ventilation. And the lung protective ventilation, for those of you who are not familiar with, is the settings of giving the patient low tidal volume and high frequency if they have low compliance, because they have very stiff lungs due to the consolidation of the lungs. And such stiff lungs is not easy to ventilate. So try to compensate this by increasing the minute volume, by reducing the tidal volume to reduce the plateau pressure, and avoid worsening of the lung mechanics and injury of the lungs by the mechanical ventilation. And to try to wash out the CO2, you increase the respiratory rate. And we often allow a degree of permissive hypercapnia on these patients, meaning that you will not be able to clear the CO2 completely. You would allow a degree of respiratory acidosis, which can be variable between 7.25 to 7.20, allowing the CO2 to increase, keep them sedated, paralyzed, but your aim is to maintain the plateau pressure, which is the intra-alveolar pressure, less than 30. So low tidal volume, 4 to 6 mL per kg. Again, your oxygen will be titrated according to your aims of oxygenation, PO2 more than 8, saturation from 88% to 92%. Respiratory rate will be on the higher side because you try to give them a bit of higher minute ventilation, but again, you will allow permissive hypercapnia. Your PEEP, you will be allowed to use higher PEEP. And intensivists will know that we have a table of correlation between the PEEP and the FiO2, and we have a sort of bundling of the level of PEEP as correlated to the FiO2, which you should not use it in the type L. You should not couple the PEEP with FiO2 to avoid recruiting the lungs because they don't require recruitment. But in the type H, this type, you can couple the FiO2 and the PEEP, and you can go up with the PEEP if you have high FiO2 requirements to try to reduce the FiO2 to the minimal required level. Proning is needed usually every day in the type H as well to help redistribution of perfusion and helping improving the oxygenation and opening up the atelectatic airways. Sedation and paralysis is a must. And again, you have to be patient as always. So now we intubated the patient. We followed the patient up every day by clinical assessment, by lung ultrasound. We did CT just if we can for these patients to help identifying the lung pathology in accuracy. And now we decided to wean the patient. So when you wean the patient, remember COVID-19 is a long-lasting disease. You should avoid early weaning. And I'm repeating that, I'm stressing on that. It takes an average of 10 to 14 days on the ventilator, which can be less, can be more. And avoid the negative early inspiratory swings when they breathe hard spontaneously. We are usually thinking in a positive way when we are weaning patient to let them breathe on her own, breathe hard, because we think that we are training the respiratory muscles and letting the diaphragm work. But that doesn't prove useful in patients with COVID-19, especially in the beginning of the disease, because this can have damaging effects on the lungs. And it is called a form of self-inflicted lung injury from the active breathing early on the disease when the lung is not healed from the disease. So when we decide that they are ready for extubation, we saw that extubation CPAP is useful. So in our unit, we have the CPAP hood, which is applied all over the face. But I think any form of CPAP is useful because these patients tend to de-recruit easily after extubation. Even if you do it after 10 to 14 days, they are still at risk of de-recruitment and collapse of the airways. So extubation to CPAP is advisable. And we also tend to keep them on the CPAP for longer intervals, especially in the first 24 hours. And then we come to the role of lung ultrasound, which is useful to monitor progression and guide weaning from the ventilator. We use it usually to monitor our recruitment, to see the level of aeration in the lungs, to see the effect and response to proning and help weaning from ventilation. And this is a study which shows you the significant increase in the number of publications on lung ultrasound from the 70s until now when you search it on PubMed. And we all know the advantages of using ultrasound in the point of care. It's very immediate, available at the bedside, repeatable. Lung ultrasound is not difficult to learn, and you will have a steep learning curve if you learn it well under good supervision. It is rapidly applied at the bedside. It saves cost by reducing the number of X-rays done on the unit and even trying to reduce the number of CT scans performed. And it reduces exposure to radiation, and it reduces the exposure of healthcare professionals to the COVID-19 patients if you are avoiding moving the patient out of the bed space and reducing the requirement for doing CT scan. I'm not saying that the CT scan will be replaced by lung ultrasound. CT scan is still the gold standard in imaging the chest, but lung ultrasound can provide useful and can be correlated in a positive way to getting important information, which reduces our need for CT scan. To perform lung ultrasound, you have different probes, but the main probes that you can use in the intensive care is the curvilinear probe, the low frequency transducer to image the parenchyma of the lung, to monitor for aeration and seeing the normal aeration or the loss of aeration or the moderate loss of aeration in the form of B lines, which is common in COVID-19. And the other probe is the linear probe, which is the high frequency probe, very good in seeing the pleura and looking at the pleural health and checking if there is any irregularity, any pleural thickening, or the presence of subpleural consolidation, which is important finding in patients with pneumonia in general, especially in viral pneumonia and COVID-19. The cardiac probe can be used as well. And some people were asking whether we can use it. Yes, we can use it. I mean, it gives you less depth than the curvilinear probe, but it is a good probe to be utilized, especially as part of your echocardiography study, as an extension of your echocardiography examination, and it has a smaller footprint, so it fits easily in the intercostal space. And these are the different zones in the lung. There are several protocols for dividing the lungs into zones for doing the lung ultrasound. This is one of them, and this is the one I commonly use. You have 6 zones on the right and 6 zones on the left, 2 anterior, 2 lateral, and 2 posterior. It might be or usually difficult to get these posterior zones in mechanically ventilated supine patients, but I try to get as posterior as I can, posterior to the or behind the posterior axillary line to get the lowest part. And as we always say, the devil always hides in the backside. So you have to try to get as posterior as you can when you scan the lungs. The horizontal imaginary line here is almost the nipple line. And the location of your probe is depending on what you are looking at. In pleural effusion, you put your probe at the costophrenic angle. In heart failure, you look at the dependent zones. In pneumothorax, you look at the non-dependent zones for any signs of pneumothorax. And these are typical clips of a patient with COVID-19 where you had very thickened irregular pleura, subpleural consolidation. This is with a linear probe. And for example, if you look here, the pleura is a bit thickened, but it is not very irregular. And you see some vertical artifacts arising from the pleural line, which could be B lines if they are extending to the far field, if we see with the curvilinear probe. But if you compare this to the pattern of the irregularity of the pleural line here, you can see clearly how the pleura is very thickened, irregular, with big subpleural consolidation, which is this hypodensity under the pleura. I see this quite a lot in patients, especially the sick ones admitted to the unit early on the disease. And when the patient heals with time, you start to see improvement in the lung thickening, reduction in the lung thickening, and sometimes we see reduction in the size of the subpleural consolidation. And when you scan the patient with the curvilinear probe, this is very typical. It is typical for ARDS, but we see it very common in patients with COVID-19. This curtain-like patchy alveolar edema. So the B lines are vertical-like comet tails, which reflect increase in the extravascular lung water. So increased or the presence of fluid in the interstitium or alveoli can cause the presence of these vertical comet tails. And here you don't often, or you don't even see isolated B lines because they are plenty, they are a lot, and they are combined together in a confluent way to make this shiny white curtain. So the normal aeration of the lung is almost this black part with the pleural line here, and this mirror-shaped artifact of the pleural line, which is the A line. So this is an area of preserved aeration, very adjacent to an area of moderate loss of aeration, where you see this curtain-like bright B lines. Why I'm saying moderate loss of aeration? Because when you have loss of aeration completely, you will not see B lines, you will see consolidation, which is the transformation of the air into tissue instead of fluid. So you have the air, you have the fluid, you have the tissue. A pattern, B pattern, and C pattern. Air, A lines, B, B lines, C pattern is consolidation. And here you can see the irregularity and thickening of the pleural line. And we have also the lung aeration score, which is one of the scores proposed to get an idea of the degree of aeration. And you can do the scoring on a daily basis, or more than that or less than that if you think it is useful. And it's a tool that could enable you to monitor the progression of aeration in these patients. And when I do that, I see the progression of the scoring and the reduction of the number of the score, which reflects an improvement in the aeration of the lungs. And this is the same patient after almost 10 days of ventilation. You can see the improvement of the pleural line and the reduction of the thickening of the pleural line. And here with the curvilinear probe, you see more black, and you clearly see bigger areas of A lines, predominant A lines, and few B lines appearing laterally here, and almost here, almost A lines across the zone. But remember to examine the lung systematically in all the zones. So clinical benefits of lung ultrasound are quite plenty. It is useful for prognostication. Some centers in Europe use it for triaging the patient to decide which is the clinical pathway for the patient, whether they will be admitted to the hospital, managed at home, or admitted to the intensive care, depending on the pattern of aeration and the clinical manifestations and the level of hypoxemia. It can be utilized for risk stratification and assessing disease progression. And this is the data set released from the Intensive Care Society, showing the different patterns observed in patients with COVID-19, whether it is the predominant type B, the predominant B lines in patients with the L phenotype, or the predominant consolidation in patients with the L phenotype, with H phenotype, and consequently thinking of a clinical decision making based on that, whether you will prone them or give them PEEP. But remember, we should apply PEEP carefully to patients with type L, and we can prone them to help improving the oxygenation by redistribution of the lung perfusion. And don't forget the integrated approach. It's very important to put in mind that you will have to use all the imaging modalities that you have, scanning the heart, scanning the lungs, looking at the pleura, looking at the IVC, the deep veins, and also scanning the diaphragm. This will give you an idea about the patient overall, and put this all together in the clinical context. Imaging should not replace your clinical decision making. And we have limitations for it, or like any other diagnostic modality. It may miss pathologies deep within the lungs, limited evidence-based data. It is still very evolving field in imaging, and the potential for human transmission of COVID-19. And let's admit it, we know very limited information. We have very limited information about this pandemic. Most of our practice now is based on experience, very limited evidence, and we are still in the very beginning of our understanding of this disease, which is a huge challenge for every one of us. So my take-home messages, therefore, will be patient with your COVID-19 patients who are ventilated, give them time, allow the lungs to heal. New disease with very limited experience on therapies. We are still learning on the go, so we have to be very careful when we are managing these patients. Lung ultrasound can be useful if applied at the bedside as a monitoring tool, and we should always remember the integrated approach when we are managing these patients. Try to get all the imaging modalities together in the clinical context. Thank you.
Thank you so much, my dear friend, Dr. Hatem Sulaiman, for this really interesting presentation. I have really enjoyed every single word you have said.
Thank you, Dr. Ahmed.
I have a question, please. You have said that you depend mainly on lung ultrasound for extubation for ventilated patients. As you know, lung ultrasound is not available in many countries, and no many experts in this field. What do you suggest to depend on to extubate the patient? Can we ask for CT or X-ray, or you depend on the saturation, blood gases?
Yeah, of course.
As an alternative for the lung ultrasound.
Yeah, of course. I mean, if you don't have lung ultrasound, of course, you will rely on the clinical information. You will use the chest X-ray, but the idea is the same. You have to give the patient time. And I mean, as people observe, there's no evidence on that. This is all experience-based. 10 to 14 days, some people do after 7 days. If you see your patient clinically ready, hypoxia is improved, X-ray showing reduction of the infiltrations, yes, you can use the clinical and X-ray criteria and guide your extubation. Lung ultrasound is not a mandatory thing to do, but it is useful if you have it to utilize it.
Can I just give a comment here? With lung ultrasound, things are completely different compared to CT scans and to normal echo. The worse is your machine, the older is your machine, the less artifact suppression algorithms it has. And you see the B-line is much better. So you are actually not restricted by the fact that you have just old technology. You can just find an old echo machine in your unit. You can dedicate it for a COVID patient to avoid disease spread. And it's much easier to learn lung ultrasound than, for example, transthoracic echocardiography. So I think anyone who's dealing with this patient has to start doing it, and that there's no limitation based on machines and availability of machines. Just find some old machines and start doing it, and you'll get used to it, patient by patient, patient by patient.
If you have a machine, you can definitely learn it, and it doesn't take time to get yourself able to do it. But I mean, your question is mainly if you don't have a machine. So if you don't have a machine, your world will not stop. You will do the same thing. You will assess clinically, you will do the X-ray, but the main thing, be patient. This is the only thing we know about COVID-19 respiratory failure. Be patient. There is no evidence that any of the medications work so far. And we saw patients that improved without any treatment, without hydroxychloroquine, without azithromycin. They just had their time on the ventilator and improved and extubated. And a lot of them we saw, they went home successfully.
Great. Dr. Muhammad, can we have the question from the audience, please?
Okay. So, question from our colleague, Dr. Fadi Aziz. He thanked you for your great lecture, Dr. Hatem, and he is asking if you recommend increasing PEEP levels up to 20 centimeter water in the H type for further recruitment of the lungs, if they are on FiO2 80%, or would that reduce the venous return?
I mean, I cannot recommend a number of PEEP because this is very variable, and we intensivists know very well that when you apply PEEP, you should apply it in a gradual way in the setting, in the light of the FiO2. So we have the table for the correlation between PEEP and FiO2. So, and again, when we apply positive pressure ventilation and give PEEP for recruitment, we have to carefully assess the right ventricular function. So I can never recommend giving a number of PEEP without knowing how much FiO2, how is the clinical condition of the patient, how is the blood pressure, and how is the right ventricular function. So it's not that easy, I'm afraid.
Okay, another question from the floor, Irina Iki. She is asking about your protocol in treating COVID. Do you use antimalarials? Do you use azithromycin? Your opinion about the antivirals, favipiravir, remdesivir, and the immunoclonal antibodies like tocilizumab. Do you use these agents in your daily practice?
So far we only, initially when the pandemic started, when we started getting patients in our hospital, we had an agreement that we will start with hydroxychloroquine and azithromycin as a protocol to our patient. But then we noticed a progressive increase in the QT interval to dangerous levels in these patients. And then when we started to see reports from our colleagues that, yeah, we know that from the start that there's no evidence behind this. So we started to stop them one by one. And currently we don't have recommendation in our place to start any of these medication. I have no experience with the antivirals, and I have no experience with the immunoglobulins in COVID-19. So my message is clearly, I see that these patients get well with time on the ventilator with no specific treatment. I have no clue about any specific successful therapy so far.
Maybe complementary to this question, did you see cases with myocarditis?
Yes.
Where did you think about using glucocorticoids or immunoglobulins in these cases?
Yeah, we do saw cases with myocarditis, and we even used immunoglobulin. We used steroids in patients with the type H, so not even with myocarditis. Again, there's no evidence. It's all clinical-based, experience-based practice. We heard from our colleagues in Italy and Spain that a small dose of steroids can be utilized in patients with the type H, and we do use it sometimes in some patients. And I'm not sure if this is the cause of their improvement, but I had 2 very sick patients on the unit, extremely sick. They were the type H, they had the cytokine storm, they were elderly. They were 2 among other very sick ones, but these 2 patients recovered and improved. And one of them had tracheostomy and the other one is extubated. I'm not sure if steroids is the cause, and I doubt it. But the answer to your question is, we sometimes feel when we see the patient is very unwell, we use 1 to 2 milligram per kg of methylprednisolone for a very short course.
There's another question from Dr. Muhammad Abdul Wahab. He is asking about the role of non-invasive ventilation in treating L-type as a primary mode of ventilation.
Yeah, I think this is a good question. I think the L-type, we see patients, intubated with 40% FiO2 and people of 8. And we think that they could have been managed successfully with the non-invasive ventilation. So I think non-invasive can be useful in this patient only if it offloads the respiratory function. If the patient works hard with the non-invasive ventilation, I think it's not a good idea to continue with NIV. Otherwise, they will have the self-inflicted lung injury that we discussed in the presentation. But if NIV succeeds in offloading the respiratory pattern and improving the breathing condition, I strongly recommend NIV.
Okay, I think it's clear now. Other question from Dr. Hasib Reda. The question is directed to you as well, to Dr. Alexander, if you would like to share the answer with you. Do you have a comment regarding plasmapheresis in COVID patients?
We haven't used it. I don't have experience in it.
Dr. Alexander, maybe?
I've never used that. Theoretically, it should work. We don't have enough patients in Bulgaria, so we have very few patients here. We have like 800 official patients and about 40 deceased patients. So we've not developed any pool with that. So we are waiting. I think they're planning to use that in US, and they have plenty of cases in New York. So I hope they'll publish their results, and we see how it works from that.
We will see. The next question may be to you also, Dr. Alexander. Do you see any difference in anticoagulation regarding the prophylaxis of VTE between L and H types of COVID patients?
I think the main difference there is how to ventilate and how to manage the patients. I would be more aggressive than with the normal patients in both types. I think this disease is very prothrombotic. Of course, I speculate here and I can't prove it, but the minimum of the enoxaparin that I would use would be 40 or 50 milligrams twice daily in a normal size man or woman. Otherwise, if it's a heavier man or woman, I would go to higher doses.
Okay, I think we are done with questions from the
maybe I have one thing to mention. Probably we didn't discuss. It might be related to the plasmapheresis question.
Yeah.
We have experience, and we used several times the cytokine absorption hemofiltration, and I'm not sure again. This therapy is very lacking in evidence, and globally only case reports available on this. But again, the two patients that I saw survived and were very sick and had steroids, they were both put on extended periods of cytokine hemofiltration. And I do feel that even before the COVID-19, from our experience with cytokine absorption, that there might be a benefit, might be a clinical benefit from it. But I'm not quite sure again, but I think maybe it's important to put it in consideration.
And something else I would like to mention, certain parts of the patients will develop acute kidney injury, and they will require renal replacement therapies. And it has been reported by many colleagues from Central Europe and Italy that the machines get clogged. So even on heparin, even on high doses of heparin, even on citrate, it happens.
We see this a lot. The filter clots very frequently in these patients with high dose of heparin, and it is a very aggressive disease in terms of thrombophilia, and that's very correct. We struggle with them sometimes with anticoagulation. Even we had to put patients on argatroban sometime because when they fail, when they don't respond to heparin, and some of them have liver failure, we don't have the option of using citrate, so we put them on argatroban. And that's probably the only thing that worked well with some of them.
Great. At the end of our webinar, I'd like to express my deep thanks and gratitude for Dr. Alexander Nosikov and Dr. Hatem Sulaiman for their excellent presentation. And I'd like to express my deep thanks and gratitude for my co-moderator of the session, Dr. Abdallah Al-Maghrabi and Dr. Muhammad Hamdi. And see you in another webinar soon. Thank you so much.
Thank you so much, my friends. Stay well and safe. Bye-bye.
Thank you. Thank you.
Bye-bye.
Bye-bye.
Bye-bye.